So our next speaker is Dr. Sajeev Thomas. He's a GI physician at the University of Florida Cancer Center in Orlando, Florida. So please welcome Dr. Thomas.
Again, my name is Sajeev Thomas. I'm medical oncology at the University of Florida in Orlando. And so half my practice is actually melanoma, sarcoma, the other half being GI oncology. So I have the pleasure of seeing a lot of different tumor types in these broad fields. I have two apologies. One is if you try to follow the slides in the book, it's going to be out of order. Okay, Bob had asked me to put slides in last week. I said I probably won't even looking at it till 2 days ago. And then number two, I did not bring any heat from Florida. Okay, it is very cold up here, but I love the cold, and so there's I think it's a great thing. In Florida, we probably had 2 days of cold. The temperature was like 20, 30, and we had people out in coats and boots, and it was embarrassing. And I'm from Chicago, so I kind of love the cold. Now, I'm hoping my job over here is to kind of talk about all the different types of medical therapies that we have for bowel and pancreatic neuroendocrine tumors, kind of put it all together with what we've had with chemotherapy and targeted therapy, and I'll even touch on immunotherapy because that is half what I do as part of the melanoma world, and I think that is broadly changing a lot of different tumor types. This is sort of repetitious. As you guys already know, there's a lot of different factors that I look at when I see a patient with neuroendocrine disease. Number one, what's the site of the disease? Number two, the stage. Three, the grade. Four, is it functional? And why is the site very important? As you guys already heard earlier today, there's a big difference between knowing if a neuroendocrine tumor is coming from the pancreas, because in my world, if I see a neuroendocrine tumor that's from the pancreas, they tend to be a little more chemosensitive, number one. And number two, there are some readily available FDA-approved options that I don't have to argue with the insurance company with, okay, number two. Number three, there are some behavioral differences. Number four, there are some prognostic differences between the pancreatic neuroendocrine tumors as well as the various carcinoid tumors from various subtypes. Everyone in this room probably already knows the difference between a stage 1, 2, 3, and 4. Obviously, it's curative intent with stage 1 to 3, but when it's stage 4, our treatment paradigm might change from a surgical approach to more systemic approaches, but that just depends on exactly what's going on with the patient. Now, grade, we've already talked about this. This is very, very important. How do we know this? Well, we talk to our pathologists. We ask them to look at the tumor. What proportion of the cells are actually in division? If it's less than 20%, typically that's a well-differentiated tumor. It's typically a low or intermediate grade. And if it's greater than 20%, as you guys already heard today, it's typically a high-grade disease. I take it a step further and say, well, let's look at the folks who are 20 to 40%. And I actually been able to manage, and I have a couple of patient cases on this, where you can manage some of these folks who are in the range of 20, 30, 40% and treat them with the same paradigm that are very similar to what we do in the well and differentiated, well or intermediate grade folks. And I have some good examples of that as well. And four, I already told you, functional symptoms. Obviously, this can be more of an issue than even the disease itself. We've all met some patients where they had the disease for maybe 10, 15, 20 years, and it's not the disease that's the problem. The problem is the functionality, and it's all about quality of life at some point, right? So nobody likes it when we go to the bathroom. Well, actually, I guess most of us prefer if we go to the bathroom 3 or 4 times a day. I've had patients tell me this is great, but when you're locked down in the bathroom like this for 10 times a day, then life is pretty frustrating. We want to try to get on top of that in the palliative care intent. Now, when we talk about all the different interventions we have, there are approaches that what we call disease control, okay? Interventions, whether that be therapeutic or surgical or interventional with IR guys that provide not disease control. Number two, symptom control. There are some therapies that we do that don't affect the underlying condition, but can affect the outcomes in terms of symptom control, okay? Improve the quality of life. There are some things we do that kind of do a 2-for-1 special, right? We like 2-for-1 specials. Please treat my symptoms and also treat my disease at the same time. You can accomplish that fairly well with some cytoreductive approach, so debulking, reset the clock, and as well as improve the symptoms. Take out the factories that are making serotonin. Number two, somatostatin analogs. You guys heard this many, many times today, that these drugs not only control the symptoms, they have the ability to control the disease. And there's other approaches with liver-directed therapy, peptide radionuclide therapy, and some of the chemo and targeted options, which I'll touch on. For symptom control, we'll do everything we can to try to control the diarrhea. There's a new drug from Lexicon, Felitrostat, which I'll touch upon toward the end, okay? And as you've already heard many, many times today, the care of these patients are best done in a multidisciplinary setting. It's almost, literally, we're sitting around a room with a pathologist, radiologist, our radiation oncologist, everyone talking about what we all do. We're all good at something. How can we measure the pros and cons, the risk, the benefits, the logistics of providing all of these therapies to our patients so that we can control the disease in the long term? This is a marathon, and I hope to make it a marathon to try to control this and make this disease a sort of a chronic problem as opposed to an acute problem. You've already heard about this, right? We got somatostatin analogs that bind to specifically somatostatin 2 and 5, and for those who are graphically inclined, you take a tumor out, right? You got 1 billion cells in there. At the surface of the cell are somatostatin receptors, and it's making serotonin or chromogranin. And then when you inject with somatostatin analog, whether it be octreotide or lanreotide, these things make their way in circulation and grab onto the receptors and basically shut it down. It suppresses the release of serotonin or insulin or gastrin, a variety of different things that it can do to suppress it. Now, we've learned for a long time, we've already knew this for a long time, that these drugs have a great control of symptoms, whether it be octreotide or lanreotide. Dr. Larry Coles, I used to work with him when I was at Moffitt, again, in the order of 70, 80%. And Dr. Odoriso was just saying that, yes, I did not know it's a randomized clinical study. I closed my ears when I heard that. Usually many things that we do in medical oncology required a placebo-controlled study to prove that its outcome. But octreotide just works. And asking for a randomized control study in octreotide is kind of like asking for a randomized control study to use a parachute, right? It just works. You're not going to test that theory, right? And so this is pretty well established. Octreotide and lanreotide have great control of symptoms. And in some patients, you may need to be using some short-acting in the meantime. But for quite some time, we didn't really know if it really controls the disease. And as you've already heard today from the PROMID data, this was published in the late 2000s. This is where they took just the well-differentiated mid-gut tumors, so no lung, no pancreas, well-differentiated folks, and you said, all right, you have to take the octreotide and you have to take placebo, and I'll check a CAT scan every 2 or 3 months, and let's see what proportion of patients are actually progressing. And so I know a lot of people are not familiar looking at survival curves, and so if you look at the red line, which is the octreotide therapy group, and the x-axis is the time to progression, and the y-axis is the proportion of patients who have progressed. If we follow that red line over there, what is the average time before 50% of the folks actually progress? It was in the order of 14 to 15 months on average. Okay, that's not survival, that's progression-free survival. Now, if we look at the placebo group, what was the average time before 50% of the folks progressed at that point in time? So if you go to the 50% mark, you go down, it was about 6 months, okay? So the very first study to show that you can actually control the disease on top of controlling the symptom. Now, many of us who were treating pancreas and lung neuroendocrine tumors, we extrapolated from this data, right? This was the only data that we have that actually said that it can actually control disease. Up until the CLARINET data, which was just presented and published last year, they looked at lanreotide in folks who have pancreas, mid-gut tumor, and high-gut tumors, and they specifically limited their patient group to just non-functional types. So there was no functional types in this particular study. They also included folks who were intermediate grade. The other study did not. It was mostly low-grade folks. And then they also limited the study to octreotide avid. Now, what they did in this study that the PROMID folks did not do is a CT scan, 2 CT scans before they randomized the study. 2 CT scans, and why did we do that? Well, as you already know, a lot of neuroendocrine cancer patients typically may not have significant progression, even off therapy. And so this was a way to get a status of what was their status, what was their disease doing at the time that they were randomized into the clinical study. Okay, and that's how you do it. So you do a CAT scan at one point, you repeat the scan 3 to 6 months. What proportion of patients were stable? What proportion of patients were actually progressing? You want to know what the numbers were? 95% of the patients were not progressing prior to randomizing into the study. It's about 95%. So most people had stable disease while they were randomizing to either lanreotide or placebo. And then you said, all right, you got lanreotide or placebo, you did it every 4 weeks, and then I'll watch you repeat the CAT scan every so often. What proportions were progressing? If you look at this curve, you'll say, wow, this is a heck of a lot better than what we saw with octreotide, right? So let's see the lanreotide. What was the average time before 50% of the group actually progressed? Well, 50% of the folks did not progress, right? About 60, 70% of the folks were progression-free at 2 years. But if you got placebo, right, what was the average time for 50% of the folks to progress? It was 18 months. Must have been a very nice placebo shot, right? What was in that shot? So at 2 years, 40% of the patients did not progress. And that's very interesting data, because there's a lot of folks where maybe the disease is not progressing. They're completely asymptomatic, they have low volume disease. It may not be a bad option, especially if they're elderly, where maybe just observation and considering a time to pull that trigger of using these drugs at a later time point. But what you can sort of gather from these two studies is that somatostatin analogs are good at controlling symptoms. They're also good at controlling the disease, number one. And number two is that maybe some patients, it may not be an unreasonable option to just sort of watch and see how some patients do, pulling that trigger to kind of start therapy if they have some significant progression. This is controversial in terms of the timing to start therapy. What is considered significant? It might be centimeter for me, it might be 5 millimeters for you. And this is something we talk about in some of our tumor board conferences. Now, it's relatively unknown whether if you fail one drug from a symptom standpoint, or if you fail one drug from a progression standpoint, will the other one work? I don't have the answer to that. I don't know if anybody does. Number two, what is the optimal timing to start therapy? And then three, does it work in lung nets, which, again, those kinds of folks were excluded in those studies. But all of us believe that this kind of therapy will probably be very effective for most patients with NET tumors of any type. All right, this is a second, third generation somatostatin analog. This was also tested in a phase 3 study, but specifically to see if it can control symptoms compared to a higher dose of octreotide. And the answer is no, it did not. They stopped the study early. But what you did see was some interesting data that the folks who got octreotide, the average progression-free survival was 12 months versus octreotide of 6.8 months. Again, adding to what we've known that somatostatin analogs can control symptoms. Now, what about side effects? Now, in my world, I do immunotherapy, we do chemotherapy, IL-2, biochemotherapy. Somatostatin analogs in my world is probably the easiest drug to give, okay? Maybe injection site pain. I had one patient where I forgot to tell him that it was going to be a buttock shot until he actually showed up to the infusion room and realized the nurse had said to bend over. Number two, nausea, diarrhea. Yes, it can affect your thyroid. Yes, it can cause some hyperglycemia. I respect the diabetic folks who may have some glycemic issues. And so if they're on this drug, you want to watch for those particular problems. Now, here's a patient I had 3 years ago, about 40-year-old lady. She presented with maybe 4 bowel movements a day, maybe 2 or 3 episodes of flushing episodes per week. And she thought that was just normal. That was just how people roll, right? And then I think she came with some abdominal pain, and they thought it was gallbladder. Did the CAT scan and found a couple of spots in the liver. And if you do some chromogram A, it was 2,500. The serotonin level is 165, and she's clearly very avid disease. Here's her liver before we sent her to surgery. Obviously, her liver's right over there. You can see these huge spots on both sides of the liver. She has met some surgeons, and the surgeon said, I'm not touching that. Because in the world of surgery, many surgeons feel that if you can't clear the disease completely, they're just not going to operate on that. But that, in this situation, is a little bit different. We're not talking about completely clearing the disease. We're just talking about debulking as much as you can, reset the clock, and hopefully, if it took a long time for those big ones to occur, how much more time will it take for those little ones that you know are there to progress to this size over time? And so here's a liver before surgery. Here's a liver after surgery. It's beautiful. If we gave a drug like this to get a complete response, we pat ourselves on the back. And this is a surgeon who did this and did a great job with it. Now, at the time of surgery, they found a lot of tiny little dots, and we knew that was going to happen. A lot of tiny little dots, miliary disease throughout the liver, and also some tiny little dots throughout the peritoneum. This was coded, it literally scudded the peritoneum around the bowels and also the diaphragm. For that reason, I actually recommended that you should stay on sandostatin after the surgery was done. Now, she was on it for about a year. She did great, and then after a year, she said, Mom, I'm done with the shot. I want to stop it. Now she's a year later, still doing very, very well, and I'm just watching her until she has symptoms Now, that was a low-grade neuroendocrine tumor. Here's a patient that I saw with a high-grade neuroendocrine tumor. The Ki-67 was 22%, had a cycle of chemotherapy before he saw me, did an ultratype scan, was very, very avid. You can see the chromogranin A about 36,000. This is where I put him on Sandostatin and asked my IR colleagues, hey, can you just taste this? Just go nuts with this. And he did a bilateral taste both sides. And you can see that the chromogranin A went from 36,000 down to 2,000. And that was in 2013. And then I just maintained him on Sandostatin. Here's the scans in 2013. This is mid-2013. You can see the liver literally chock full of disease. Here's a scan as of February this year. He's a year and a half being told that he only had 6 months to live for a high-grade neuroendocrine tumor. He's doing great, right? So some of these folks can be managed a little bit more like a well-differentiated folk. Now, what about chemotherapy? I'm not a big fan of chemotherapy. I don't like it. I wish we can kind of do away with it, but we still have it, and there is a need for it when we need to do it. What does chemotherapy do? It interferes with the replication process of DNA, but it's very non-discriminate. Any cell that's rapidly dividing the body, this is what chemotherapy will attack. And so what are the normal cells in the body that do this? Your hair follicle, the lining down from your mouth to your anus, so hence nausea, vomiting, diarrhea, and then the bone marrow. The bone marrow is a factory to make the white cells, the red cells, the platelets. So risk for infection when your white count goes down, the need for a transfusion, that kind of thing. But when you give chemotherapy and it attacks a cancer, you like to disrupt that replication process, at least to cellular destruction and apoptosis. But as you heard earlier today, it doesn't completely eliminate all the cancer cells. Eventually, even if you had a complete response, eventually it's going to come back again. Now, chemotherapy can't be given IV or oral. We often wait for when it's metastatic disease. I have one little blurb on high-grade cancer. So the folks who are Ki of 80, 90%, we're doing surgery and or radiation with chemotherapy. And those kinds of folks, if it's extensive and metastatic, it's just chemotherapy to try to control it for as long as we can. And that's an area where we really need something there because it's kind of struggling. Now for the low, intermediate grade neuroendocrine tumors in pancreas folks, if you guys remember in the beginning, I told you pancreatic neuroendocrine tumors tend to be very chemosensitive. Here's an example of disease in the liver before chemotherapy, and here's an example of the liver after. So we can see some very, very impressive responses with the use of temozolomide and capecitabine-based therapy. That tends to be my preferred regimen if I'm going to do chemotherapy, especially in pancreatic folks. But in bowel folks, it tends to be an option of last resort. I definitely don't rush to chemotherapy in those kinds of folks. Folfox, there is data for Folfox. There's the old data for streptozotocin and doxorubicin. I've yet to use that regimen, but I might consider it if we're running out of options. Now, raise your hands if you actually read this book. Anybody read this book before? Only 2 people? 3 people? So the rest of the people don't like to read a book, perhaps? It's a New York bestseller. Okay, New York bestseller. This tells the story, the biography of what the heck we've been doing in the world of oncology for the last 100 years. It's a great story. I should get a promotional fee for actually how many times I actually talk about this book. Easy to read. Anybody can pick it up and read it. And again, it tells the story of what the heck we've been doing. It's been chemo after chemo after chemo, more chemo, 4 drug regimens, and it really hasn't gotten us anywhere. But over the last 10 to 15 years, we've had a lot of exciting insight, especially in the world of neuroendocrine tumors, and now even more so in the last 2-3 years with the use of some immunotherapy options that we'll talk about. Now, in the world of neuroendocrine tumors, we knew that we now realize that the mTOR pathway, this is like looking inside the cell. If you look at the mTOR pathway, it is upregulated. This leads to increased metabolism, increased growth, and also increased new blood vessel formation, okay? And what if we had a drug that could just target that particular pathway that's inside of a neuroendocrine tumor cell? As a tumor gets big, right, it needs blood vessels. It needs new blood. It needs nutrients to survive. How does it do that? Well, it secretes VEGF. Those little blue dots blue dots over there, VEGF, VEGF, vascular endothelial growth factor. This vascular endothelial growth factor binds to the receptors on a blood vessel cell, and that's basically the tumor telling, hey, come feed me, I need some new blood vessels. And every time you take these tumor out, they're very, very vascular tumors, very fragile blood vessels. What if you can target that VEGF? What if you can target the receptor? That's how Avastin works, that's how Sutup works. Okay, everyone with me with that? Now, so mTOR pathway, the VEGF pathway, This was tested formally in a pancreatic neuroendocrine tumor, 2 different studies. These were phase 3 randomized studies. So basically said half the folks with progressive, the key word is progressive, pancreatic neuroendocrine tumor, low intermediate grade, okay, that was the requirement to get on the study. You either get mTOR inhibitor versus a placebo, and how did you guys do? That's one study. Number 2 study is half the folks get Sutent, the other half get placebo. That's the second study. I put all that information to one slide, okay? So if you got mTOR inhibitor, your average time to progression was 11 months. If you got Sutent, literally the average time to progression was exactly the same, 11 months. There was virtually minimal response, minimal shrinkage of disease. So for most people who take this drug, it's not going to shrink it down. Some people will get some shrinkage, but for most people, it'll be more static. It'll keep it at bay for the long term. And the primary difference between these 2 drugs is the type of side effects. What kind of side effects do you want to deal with? Stomatitis or mouth ulcers, diarrhea, rash. If you're taking Sutent, diarrhea, hand-foot symptoms, and hypertension probably more the common things that I've seen with using Sutent therapy. An unknown question is if you fail one, will it work if you use the other one? I don't think we have any data to say that works. I think many of us will try it if we didn't have a lot of options. But to this date, we don't have any data to say one will work after failure of the other. The cost as of a year ago may be about 10 grand per a month. And so these things are getting more expensive as times go on. This is my favorite case. This is a guy with a low-grade pancreatic neuroendocrine tumor diagnosed about maybe 5-6 years ago, and 3 years later has numerous liver spots throughout the liver. Octreotide avid, he's 40, he's young, he's got a family. They went to surgery, tried to debulk as much as they could, but left a couple spots in. And when they look at the grade, now it's 21%, 28%, 22%. Really interesting. So he went to 3 different centers. They all said platinum-based chemo, platinum-based chemo, platinum-based chemotherapy. You know, you're young, you're young, you're fit. We can always do chemotherapy later. Let's just put you on octreotide. Let's try the mTOR inhibitor. This was already approved and easy for me to get. And here he is, as of this month. He's doing relatively well, a year and a half out for somebody with a high-grade neuroendocrine tumor. So again, some of these folks can be managed a little bit differently. Now this is pancreatic neuroendocrine tumor, or before everything I said before was pancreatic neuroendocrine tumor. If we talk about carcinoid tumor, there was some studies to look at mTOR inhibitors. The FDA said it wasn't statistically different, that if you took an mTOR inhibitor and compared it to the folks who got placebo, there wasn't any difference at all, so they did not approve it for carcinoid. But if you look at the data, I didn't even put it up there, it was around 16 months versus 10 months if you got a placebo, but it wasn't significantly different, so the FDA did not approve it. But if you look at the subgroup folks, if you had a colorectal carcinoid, 29 months if you took the mTOR inhibitor, and then 6 months with placebo. And if you had a lung neuroendocrine tumor, it was an average of about 13 months of progression-free survival before versus a placebo of 6 months. So not yet approved, but sometimes we will argue this with the insurance company, try it if this is the option to do next for that kind of patient. Now there is a large RADIANT-4 study, the phase 3 study, that's already completed in non-functional lung and GI neuroendocrine tumors. I'm hoping results will be out this coming year or so. We'll look forward to that. And there's also another study, octreotide versus Avastin, octreotide with Avastin versus octreotide interferon. I'm hearing some preliminary reports that it might be more of a negative study as far as I heard, but no official results as of yet. And this is using the drug that blocks the VEGF that we were talking about, right? Blocking those blood vessels. All right, immunotherapy. Now I'm a big fan of immunotherapy. I love immunotherapy. I think it's been a very, very exciting time. I'm not, to do this talk is actually an hour long, so I got to do it in 1 hour. The essence of this is that you're trying to activate the T cells, reactivate the T cells. Your immune system has the ability to recognize a foreign invader. And that foreign invader could be a bacteria, it could be a normal cell that's been compromised by a virus, and a lot of times, and even cancer cells, and a lot of times, this little peptide, these proteins can be picked up by the antigen-presenting cell, so those dendritic cells, and the dendritic cells will present it to a T cell and basically say, hey, we have a foreign invader. This is the target. I found a piece of it. Seek and destroy it. And the T cell will recognize it, proliferate, grow, and get into the tumor microenvironment and hopefully kill it. Okay? And you can almost think when cancer develops, it's a failure for the immune system to have maybe recognized in the first place. But two, we've also realized that the cancer itself has some abilities of evading that immune response. It sort of created a biochemical shield to protect itself. And so understanding that, can we bypass those mechanisms and get some good response out of patients? Now, we participated with many of the what we call CTLA-4 inhibitors, PD-1 inhibitors. These are all immunotherapy drugs meant to treat this immune system, not directly treat the cancer, but enhance the immune system so that we can get a response. One of our first patients on clinical study where they got a PD-1 inhibitor. Now, this is melanoma patients, not neuroendocrine, okay? Melanoma patients, large 10-centimeter mass with PD-1 inhibitor started in 2013. It shrunk down to 3 centimeters as of last year. Now, as of September, it's about 1 centimeter in size. This is a drug he took every 2 weeks. He's asking me, how long do I continue with this? I said, I'll make a deal with you. I'll biopsy it. If there's no evidence of cancer, we'll stop it. If there's evidence of cancer, we're not going to stop. I always thought there was going to be some evidence of cancer. We did a biopsy. There was nothing but inflammation under that biopsy. And this is an aggressive cancer. It's nowhere near like neuroendocrine tumor. Okay. Here's another patient I had that we also started in 2013. This is what I call cannonballs. All right, cannonballs in the lung and near complete response. And we stopped his drug because he was driving every 3 hours to get the drug. He had this complete response back last year, early last year. We stopped it in June of last year. This is a scan as of February this year, and no evidence of progression. Okay, that's pretty amazing. That's really amazing. And here's another one with a mass right over here, the pre-biopsy and after treatment and the post-biopsy. You can see a lot of inflammatory cells, the T cells right over here, and melanoma cells right over here. And then after therapy, you see nothing but inflammation after the biopsy. In the world of melanoma, stage 4 disease, historically, the average survival was 6 months. 2-year survival, 10%. Okay? If you took 100 people, only 10 people survived at 2 years. The average survival was 6 months, and that's historically. If you took this drug, ipilimumab, the 1-year survival proves about 25%. If you took PD-1, it goes through a survival of about 30–40%. And with the combination of putting these two together, at least in a phase 2 study, we now see this curve going up to 80%. This is pretty exciting, especially in the world of melanoma. You get goosebumps looking at this. Okay. Then we realized, well, you know what? It's not melanoma that's also having responses. We also see it in lung cancer, so we just approved in lung cancer recently. We also see it in Hodgkin's lymphoma, colon cancer. Can we see it in neuroendocrine tumors? Well, that's actually a couple studies are probably going to be popping up. If you look in clinicaltrials.gov, there's probably more than 800, at last I heard, 800 clinical studies using immunotherapy in some form or fashion to try to kill the cancer. And so there's a group over there at UCSF with Dr. Coons looking at using the CTLA-4 inhibitor in combination with a PD-L1 inhibitor. And I know at the University of Penn, at least I'm hearing, that they're going to use genetically engineered T cells. And I don't know if this is confirmed. Huh? Preclinical, so not really, okay. So, but again, hopefully going in the direction where if we can use immunotherapy to treat the cancer, it would create another weapon in our armamentarium to hopefully kill the cancer. So that's immunotherapy. Now, peptide-radionuclide therapy, as you already heard, a lot of drugs available where you have octreotide binding to radioactive substances. I won't belabor this, but I think this is a pretty impressive picture that I saw, I think, in CNET conference in 2012. This is a patient with significant liver disease. You can see all the tumors throughout the liver. This is in 2005. This is pre-therapy with PRNT, and then post-therapy. You can see a lot of these spots disappearing. 2006, 2006, and if we go to 2007, 2008, 2009, and 2011, just one spot over there. I can see the IR guys just salivating over this, right? Or the surgeon salivating because we can do a lot of different things to one spot in the liver. So this would be a very exciting form of therapy. Not yet approved in the U.S., but a lot of folks go to Europe or go to Houston. Dr. Delpacent in Houston kind of do this form of therapy as well. Just a quick word on refractory carcinoid. We've had a question earlier about how much octreotide should you use. Well, for disease control, it's octreotide 30 every 4 weeks. For lanreotide, it's 120 every 4 weeks. But if you have symptoms, it's whatever it takes to control the symptoms. So go up on the dose, increase the frequency, use a short-acting. I've yet to sort of cross that road with using a pump. Maybe consider the alternative somatostatin analog. Interferon is a very old drug. It has its own set of side effects. So you're trading the diarrhea for fatigue and tiredness and flu-like reaction. And then talitrostat, which is an interesting drug. If you think about how serotonin is produced in a carcinoid tumor, this tryptophan is actually converted into serotonin through a lot of different metabolic pathways. And you can see that tryptophan is also a precursor to niacin. And so some people with really bad Carcinoid syndrome, at least I would be thinking about this, is that if you get niacin deficiency, one of the side effects is diarrhea. So a lot of times, a lot of people would go ahead and give them niacin replacement. But if we can do something to block the conversion of tryptophan into serotonin, that can also be very, very helpful for patients who are very, very syndromic with diarrhea. And so this is the metabolic pathway. You have tryptophan ultimately converted into serotonin. So if we can throw a wrench into the system and block tryptophan hydroxylase, that could lead to some good outcomes. I think I've spoken to some patients who are actually on this drug right now as we speak under this clinical study, but this is already completed. Okay, so if you already if you have more than 4 abdominals a day, you got a chance to go on this study. This is already completed. The data on this is still pending, but there are some companion studies for folks who have flushing or abdominal pain, predominant flushing syndrome. If you wanted to be on this drug, you can still do that. But I'm hearing good things in terms of symptom control. And just one more slide. I hope this is helpful. I hope we don't get an herb question, because every time we go to a conference, I always get a question about some herb that I never heard about. And there's a great app for that, actually. There is, really. Folks at Sloan Kettering have created an app on herbs, and you can download that on your iPhone, and it probably has every single herb listed there for physicians. Nice, concise knowledge base for physicians as well as for patients. I love the way they do it for patients. It says, the very first thing it says is the bottom line, right? This is what you need to know. And then for folks who are interested in clinical studies, clinicaltrials.gov, anybody can go to the site. Every clinical study that's ever listed throughout the world is actually on their website, and you can actually look at that and find clinical studies for yourself or for your loved ones. Again, we have a lot of options. How do we best sequence this? What are the pros, cons, risk, benefits, logistics, surgery, medical therapy? I tend to use somatostatin analogs up front because of least side effects profile, then targeted therapy, then chemotherapy. If someone has significant disease or burden disease, I might think about using chemotherapy or some other interventions where we can get a nice response, and that's where I would probably be talking to the IR guys and surgeons as well. There are things we do to provide symptom control. I think in some patients, observation is very, very reasonable. I have an elderly patient who's literally 3 years out with no progression of disease in the liver, and a lot of times the toughest part is the first step, when you actually decide to observe, and then you have to do that CAT scan. And once patients see that, hey, really nothing is changing, then you start to feel better about it. And a lot of times that's the very first step. You should be looking at your CAT scan with your oncologist. Very simple to read. You do not need to have 4 years in med school to actually look at your CAT scans. You can actually look at this yourself and understand it very well. Liver-directed therapy, radionuclide therapy, and clinical trials, I would always advocate for that if possible. And with that, I'll end.